When Professor Newman and I were in school, that was like in the 18th century. It was only hypothyroidism and hyperthyroidism. There's a whole lot more to it now. Because we're discovering people have a lot of autoimmunities, which means bodies attacking itself. And we're not sure why that is. There is a genetic component to autoimmune disorders, but a lot of thyroid disease is autoimmune. You think, well, autoimmune is only 1% of the population. But you know, it's about 80% of females of that 1%. Thyroid cancers are more likely to be male than female. Deadly thyroid cancers are more likely to be male. But it doesn't mean females can't. And the classmates who have thyroid cancer. In fact, there's usually every third year or so, I teach a student with thyroid issue of some kind. So it's prevalent. It really is. So how are you going to do this? We're going to start with hypothyroidism. Thyroiditis. What does itis mean? Remember what itis? Inflammation. Get an inflamed thyroid gland. This is why we want you to palpate for goiters. It's not like, okay, I'm going to come behind the patient and I'm going to choke them. No, you're not doing that. You're trying to determine where that trachea is, because that thyroid is a butterfly gland that kind of sits on top of that trachea. And there's a lobe on either side. And behind those lobes, there's two parathyroid glands. What do the parathyroid glands do? What do they secrete? What now? Parathyroid hormone. And what is the hormone's job? Calcium, right? It's there to. Where does it get calcium from?
Bones.
Bones. So if you think you've got an overactive parathyroid gland, what do you think it's doing to your bones?
Because
Rolling that calcium out of your bones. Nothing your bloodstream and create all kinds of problems. Mixed edema crisis is complete mixed edema coma, which is a life-threatening emergency we'll talk about. Then we'll go to the other side for thyroidism. Thyroid nodules, that's why palpate for a goiter, a very large gland, palpate for nodules. There could be one nodule, there could be a series of little bumps that you're palpating. But if you find that, it could be hyperthyroidism, that would be great, but it also could be cancer, and that's what you have to really rule out. There's lots of forms of thyroid cancer, and one's really, really bad, anaplastic. Anaplastic has a very, very poor prognosis. The one your saliva rate is really low. But let's talk about your blood labs, your biochemical markers. Remember, we always want to do that appropriate and thorough H&P followed by what is that biochemical marker? What is that blood lab that you want to get? Or the biochemical marker might be saliva. We'll find that out in adrenal disease, or it might be urine. That's your biochemical marker. Followed by the imaging study of choice. Here's the thyroid gland. Imaging study of choice often is an ultrasound. That's going to be your imaging. That's your go-to imaging study of choice. And then there's other things we can do after that. Realize T4 and T3, the thyroxine and however you pronounce that word, T3. That's how I pronounce it, T3. That comes from the thyroid. Those are hormones secreted by the thyroid. But what makes that secretion happen? Pituitary gland. Anterior pituitary gland secretes thyroid stimulating hormone, TSH. So T4, we often say free T4 or FT4. That's your active form of thyroxine. T4, that's just phenol T4, is bound, and it binds and attaches itself to proteins, but not the tissue. So it can still circulate, but it attaches itself. A lot of times we just look at free T4, T3, and TSH. So we've got thyrotropin releasing hormone that's secreted by the hypothalamus to stimulate, see how all these things work, stimulates TSH for the anterior pituitary gland. Thyroid stimulating hormone is TSH, secreted by the pituitary gland. And if you order something called a thyroid function pill, you get TSH, T4, T3. Oftentimes people just look at TSH. Oftentimes they just look at T4. If you order the pill, you get all three. There's a reason why you want to get all three. But remember, a lot of what we see in thyroid disorders or autoimmunities, body is attacking itself. There's an immune issue going on. So there's a lot of circulating antibodies against self. So TPO antibody, thyroid peroxidase antibodies, TG is thyroglobulin, DR is thyroid hormone receptor antibodies, CSI, thyroid stimulated immunoglobulins. You're like, stop, God, that's too much. They're circulating antibodies against self. When we see a big issue, a lot of times these are very, very elevated in someone's bloodstream. So here's your rule of thumb. In hypothyroidism means the gland is not producing enough T4 or T3 or free T4 or T3. And that means TSH is very elevated because that adrenal gland, the pituitary gland is slamming that thyroid full of thyroid stimulating hormone, but the thyroid gland's not reacting. It's just not doing anything. In hyperthyroidism, it's the complete opposite thing. TSH isn't responding and the thyroid hormones are going crazy, but the pituitary gland is responding. So one of the keys is hypothyroidism, if your TSH is high, your free T4 is either low or normal. So we always want to look at T3 as well. That's why when we have a thyroid function panel, it's really, you've got to have that T3 because what if it, oh gee, TSH is high, but my T4 is normal. And the T3, if it's low, then you know you have hypothyroidism. Same with hyperthyroidism. TSH is low, free T4 is higher normal, but a T3 we have. So those are your rules of thumb. Hypothyroidism. We have chronic, chronic issues with that. Well, we have primary and secondary or primary and what we call central. So in primary disease, primary hypothyroidism, the most common form is Hashimoto thyroiditis. Thyroiditis, which is inflammation. Thyroiditis. And it's chronic immune inflammation of the thyroid gland itself. Oftentimes it's caused by an iodine deficiency. Where did you get your iodine in your diet? Table salt. And whatever else they put in your food. It's all salt. Makes things taste better. What are Sour Patch Kids made out of? How do they get sour? Anybody know? It's salt and sugar. So they have a lot of sodium. So when there's an iodine deficiency, that's what causes this issue worldwide. But that's what's so funny. Hashimoto, lots of people have it. And it's only 1% of the population. You're like, well, that's kind of little. Actually, it's kind of big. 80% of that 1% are women. 5% over the age of 60. Something else you're going to see a lot of in medicine is when you start taking care of people that are over the age of 55, 60, 65, and they have a new onset arrhythmia, check that out. They have a thyroid disorder, males and females. Always look at that TSH. You got 12 weeks, but get a TSH too. Central or secondary hypothyroidism, it's a problem with TSH or thyroid producing hormone. And it's usually the pituitary gland, or it could also be tertiary, which could be the hypothalamus itself. So how do you feel that these people with hypothyroidism present to you? They're in clinic and this is I feel so sluggish. I gain weight. I look through a magazine at the pictures of food and I gain weight. It's sluggish. I'm tired all the time. Sleep 16 hours. I could roll over, hit the alarm clock. I'm like, God, I'm exhausted. I never slept all night, even though you didn't move. You're gonna go back to sleep. You're exhausted. Freezing all the time. Always cold. Depressed. Took a shower the other day and my hair came out. My nails are brittle. They break like crazy. My hair is just going down the drain. Menstrual irregularities, could be amenorrhea. Could be heavier, more frequent. Worse voice. Cold, dry skin. Well, they're not going to know that the reflexes are delayed. They're not going to know that their heart rate's really low. What's the definition of bradycardia? Heart rate below 60. Good. Below 60. Yeah. It's not 30. It's not 20. It's not that bad. Goiter might be there, May or may not be, and realize too, a goiter doesn't have to be the whole gland, a goiter can be one lobe or the other, it can be very asymmetric. But that's what they're gonna come to you, I just don't feel right, I'm so tired all the time, I just don't feel like doing anything, I feel like a slug, I eat very little, I gain a ton of weight, I don't know what's wrong. Freezing all the time. You can pulse, and it's really slow. So you do some blood labs. First thing you do is an appropriate history physical exam. Then you go worse in blood work. And you're gonna see that the TSH is elevated in some type of thyroidism. I put a normal value up there. But it varies with age. So just your free T4 is either normal or it's low. Your T3 is gonna be low. With hypothyroidism, especially with Hashimoto's thyroiditis, you're gonna see antibodies against self. You're gonna see that TPO antibody. And then there's something called subclinical hypothyroidism or hypothyroidism. There's a lot of people that fall in this range, subclinical. And what that means is your levels of your thyroid hormones or your pituitary hormone is either on the high end of normal or the low end of normal. You've got these symptoms. But when someone looks at the blood work, they're like, no, you're in normal range. That can't be what the problem is. Have you ever heard treat the patient, not the blood labs? Or not this, treat the patient? Kind of think about that sometimes. When someone's complaining of this, take it very, very seriously. Go, well, these are still normal. Some people will still treat because they're subclinical. And they may or may not have a lot of the symptoms. Their T4 is normal, the TSH is, above range, but freedom. So your treatment of choice, you got to worry about pregnancy and non-pregnancy. Remember, this isn't just for women, this is for men too. In non-pregnant patients, you're going to supplement T4. So synthetic T4 Synthroid levothyroxine. That's what it is. And our initial dose is weight-based. It's 1.6 micrograms per kilogram per day. So it's usually like 25 micrograms per day. Or 25 micrograms twice a day. What you try to do within 1 to 2 weeks, things start changing on that patient. By about a month, your TSH should be where you want it to be. You want that TSH to be below normal. Because there's variability. What makes people's hormones change? Stress in their life. PA school, PEDS test on Friday. You've got a 10K coming up. You forgot to book your hotel at Rehoboth. Those stressors. All those stressors. That's going to change your hormones. So you want it on the low normal side of the TSH. So you've got some adjustments you can make. Now, a lot of people with hypothyroidism, especially the women, this is my little anecdote, they will self-medicate. Oh, I got a wedding to go to, and I've got to fit in that dress. So I'm going to take double. Lose all this weight. It's not really a good use of Synthroid, but people do that. In pregnant patients, you can certainly give Synthroid, but you need a higher dose initially. Because remember, there's a fetus growing in there. Then you decrease that dose after delivering the child. Multiple forms of hypothyroidism. So thyroiditis, remember hypothyroidism, inflammation of the gland, it's genetic, it varies by age and race and ethnicity, but definitely females more so than males. You're looking for elevated serum levels of those antibodies against the gland itself. PPOAB, TGAB. So there's lots of categories for autoimmune thyroiditis. So we just did Hashimoto. That's the most common. There's postpartum thyroiditis, which happens 4 to 6 weeks after you deliver the baby. Subacute lymphocytic thyroiditis, or painless, sporadic, or silent. Declorvain is painful neck mass. What does that hurt mean? bacteria, a fungal thingy, a parasitic thingy going on. Friedels is IgG is mediated, and then your subclinical. I couldn't know there's so many different variables of hypothyroidism. Your main cause, radiation exposure. You're a kid and you were born with multiple palpable lip, green facial deformities, and you went through 60 surgeries by the time you were 2. That child would have gone through enormous numbers of imaging studies and a number of surgeries. What's the typical kids I took care of at Duke when I was in residency? And I always worry, who's gonna have a thyroid issue? Who's gonna have cancer when they get older because of all the radiation exposure? So radiation exposure is huge. That's the part of the things that you're gonna ask in your review assistants. How much radiation exposure? So X-rays. Certain medications like amiodarone. Amiodarone is huge culprit. So you always want to look at someone's meds. You do know, and you did know this before you came to PA school. In your previous work as a healthcare worker, you guys did some phenomenal things and impressive things before you came to school. You know, just by looking at the patient's medication list, what's wrong with them or what they're being treated for, right? If the patient can't tell you, just look at the meds list. You got a stroke patient, can't talk to you, look at the meds list, say, I got a picture. Lithium, what do you get lithium for? Biologics, the DMARDs, those things. Too much salt, so iodine consumption, excess, hepatitis C that's chronic. Believe it or not, smoking and a lot of health stuff, and smoking is implicated in the hypothyroidism. So pernicious anemia, Sjogren's, you'll learn Sjogren's rheumatoid arthritis when Professor G teaches that Sjogren's is, you have scleroderma turned to stone. Sjogren's is another autoimmune kind of an issue. What's vitiligo?
Skin hypopigmentation.
Hypopigmentation, yeah. IBD, does anybody know what IBD is? Irritable bowel disease, good. Gluten sensitivity, celiac, lupus. It's funny, they're making all these connections, all these associations with somebody's past medical history. Oh, you've got an autoimmune thyroid issue. What else do you have? Oh, celiac sprue. Oh, gluten allergy. They kind of, and you'll learn about lupus in rheumatoid rheumatology as well. Type 1 diabetes. But your antibodies against self or antibodies against that thyroid gland itself are very ill health. You can actually use those antibodies to figure out their progression. Oh, you're kind of asymptomatic, you're subclinical, but ooh, now you're really symptomatic. And now we know how to treat you. We know we can change your level, your dosing, your medication. So we just talked about Hashimoto. Hashimoto is also called chronic lymphocytic thyroiditis because the number of white blood cells of those T cells, those T lymphocytes just jam up in that gland. They build up to the point where they damage the thyroid gland and they can't produce T4 and T3. This is a chronic issue. It's the #1 cause of hypothyroidism in the United States. It's cell mediated, white blood cell mediated, T cells, T lymphocytes. The body doesn't recognize this. And it fails to recognize what happens, so it starts attacking itself. So this will go, it will burn itself out and become hypothyroid. It can go into hyperthyroidism, but that's kind of rare. What happens when you deliver a child? So we have some postpartum thyroid issues, and this happens in about 7% of women who deliver babies. And the strange thing is about it, once you've had postpartum thyroiditis, you're more likely to get it again. So 70% of women have a recurrence. Next baby, they're going to do it again. You worry about the first trimester. If you start looking at thyroid hormones in the first trimester, there's a suspicion, there's a goiter, there's antibodies. If they're elevated, more likely you're going to have postpartum thyroiditis as well. Worry about the folks that are type 1 diabetics. People that are already have autoimmune disease. Maybe they've got some lupus. Family history of thyroiditis. Family history is huge with thyroid disease. Family history is huge with any autoimmune. Look at familial patterns. Mother has a thyroid issue, the sister has a thyroid issue, her daughters have a thyroid issue. It's just all familiar. So autoimmune thyroiditis that's postpartum, thyroid releases that stored hormone, and you have a mild transient hyperthyroidism. And that's undiagnosed because it seems like everything's going okay. And that's for the first 1 to 6 months post delivery, but it can persist for a while and then it dumps into hypothyroidism. But most people after that sequela, they recover fully. When things are steady state, it's euthyroid. That's the word for everything steady state with that thyroid gland is euthyroid. Thyroiditis is painless and it comes and goes and comes and goes. Similar to postpartum, but you're not pregnant. You didn't deliver a baby. Amiodarone again. What is amiodarone used for? Right? Arrhythmia, yeah. Again, when your thyroid releases all this hormone, you've got a mild transient hyperthyroidism that's undiagnosed because it's at the high end of normal. It's followed by hypothyroidism. And then is it spontaneous, recovery? It takes a while. It's sporadic. It comes and goes and comes and goes. But it's silently, people don't really catch it. When your patients come to you with symptoms, how long has that been going on? What brought you in here today? It's been going on for like 6 months and bring you in today. I'm just tired of it. If we could go back in time and give you your life 20 years ago, you would notice a big difference as a patient. Oh yeah, I don't like the way I feel. It's just so slow to happen that they don't really complain about it. And you, the provider, they don't complain about it. You have to know it. Pruritive thyroiditis, again, you've got some kind of abscess, something going on. It's rare, it's a mycobacterial thing, it's a parasitic thing, it's a fungal thing, but severe pain, they're high fevers. They're not just febrile, they're high fevers. Tenderness, maybe some erythema surrounding that gland itself, so you know it's in that neck. What does ESR tell you? Erythrocyte sedimentation. What's an ESR? You've got some inflammation somewhere. It doesn't say here with the thyroid gland, but you make that correlation because the redness, a very tender gland, it's hard to turn their head, high fever. Rydell thyroiditis, IgG mediated, it's a hypersensitivity reaction. It's rare, but that's your middle-aged to older females that get it. But they've got a fibrosis, multifocal systemic fibrosis. So maybe they've got scleroderma too. Scleroderma, everything starts, they call it turned to stone. Everything gets fibrotic. Their esophagus, lung expansion, everything turns, this is scars. So here's where you've got one lobe is larger than the other, so asymmetric thyroid enlargement. It's very, very hard. It's fibrotic. It's becoming start open.
Are these all autoimmune? Like the ones on this page?
Are these all autoimmune? Yes, these are all autoimmune. Somehow you can't fight this off. It still goes in that category. So we go back to
Yeah, that's what I'm confused about.
yes, autoimmune. These are all autoimmune. I'm sorry. Every bit of this is autoimmune.
Are any of them not autoimmune? Like any thyroiditis, not autoimmune ever? No.
Unless it's medication induced and something's caused it, you're subclinical. That runs somebody away. Hypersensitivity. All right, these folks, hard to swallow, hard to breathe. It's that, pleural cavity is very, very constricted. Everything's painful, they're hoarse. And then some clinical. Why get antibodies against your thyroid? They're not detectable here, but something's happening because you're on the low ends of normal or the high ends of normal, something's happening. Painful subacute thyroiditis is the Curvain's thyroiditis. You think it's because you've had a virus or this is post-viral sequela and now your body's attacking your thyroid gland? Like, why would that happen? But it's super painful. The hallmark of the Curvain's is anterior localized neck pain with or without a fever. You have a real high fever or you don't have a fever at all, but your neck hurts. That gland hurts. It's post-viral inflammatory process. It damages, or that virus itself damages the thyroid. And when it damages the thyroid releases lots of T4 and T3. But you've got biochemical evidence, you got lab evidence of hyperthyroidism. Early in the stage of the illness, and then it falls and becomes hypothyroid. And what's weird about the Curvain's, it bounces back. First it's hyper, then it's hypo, and then about 6 months later, back to normal. Everything's fine. Just look at your blood work. Look at those values. So any hypothyroidism, it's autoimmune. Signs and symptoms are related to those. What are those thyroid hormones doing or not? All related to the levels of pain. And what's really hard with endocrinology is sometimes people have components of both, hyper and hypo, where you're going to switch out of one and move into the other. You just have to follow those blood labs all the time. That's the only way you're going to know what's going on. They may have a goiter. They may not have a goiter. It may be asymmetric. It might be diffusely tender. It might be nodular. It might be firm. Again, this is kind of the clues. In older females, it might be smaller, shrinking, but it's fibrotic. It's really hard. If it's asymmetric, you worry about cancer. Another thing that happens with an asymmetric thyroid gland, you might have an orange thymus. What in the world is a thymus gland and what's it for? T cell immunity. It overlies the sternum, and when you hit puberty, it starts moving, shrinking because your spleen kicks in. Why would an adult have an enlarged thymus? That's a thymoma. What they're finding, there's a correlation between an asymmetric goiter and thymus gland enlargement. And those are cancers till you prove otherwise. Patients might complain of neck tightness. They may not may just, my neck is tight. I've had patients that say, and you can see a goiter, you can see a asymmetric goiter. They'll say, just to swallow food, I get food cramped all the time. It sucks. And I don't have to eat big bites. I have to push this thingy over this mass. They're pushing basically their thyroid gland over to swallow. Yeah, that's an issue. If you think about your structures, it overlies the trachea, it surrounds the trachea, but the esophagus is behind it. So that lobe, you have to think in your head, the posterior part of the lobe is getting larger and is pushing on the esophagus, compressing it. And if you don't push that lobe over to swallow, problem. So a lot of people complain about neck tightness, but they don't really say it's painful unless you got the Curvain's. They don't really say it's painful. And women don't like to complain. Do they? Maybe they do at home. Okay. So your biochemical markers, your diagnostic studies, look for circulating antibodies. Once you diagnose this, this is really odd too. Once you made the diagnosis, watching for those antibodies and keep monitoring antibodies doesn't help you anymore. They're always going to be elevated. But you look at your TSH, 3T4, and your T3. There might be a passive release of stored hormones that increase that 3T4 over T3. but you're suppressing TSH, that's hyperthyroidism, so you just always have to look at your panel. Once you've made your diagnosis, oh, it's autoimmune, body's attacking that gland. Don't have to look at those levels anymore. Keep looking at thyroid function panel. TSH, free T4, T3. That's your best bet. Then you want an ultrasound. If it's large, it's hard. If it's ultrasound, remember, it's sound waves. Those sound waves are reduced. So decreased echogenicity. Diffuse density, heterogeneous, and it's very similar density, but you're looking for nodules too. If you've got a multinodular goiter, is it multinodular goiter? Got lots of nodules, therefore they're hyper-functioning nodules or hypo-functioning. Hypo-functioning is cancer, hyper could be just hyperthyroidism. Got to rule out cancer. Hyperthyroidism is Graves' disease. It's one of the forms. I know it's not. If you categorize it all into autoimmune, it all looks the same. What's the difference in the patient? What's the difference in the patient presentation? That's really the distinguishing part. So far, so good. Okay. After you do an ultrasound, you always have to have the ultrasound first. There's a radioactive iodine uptake, but it's the same idea. I will distinguish thyroiditis from Graves' disease for sure, because you're looking for nodules. If you've got a chronic autoimmune thyroiditis like Hashimoto, then your radioiodine uptake scan is normal, or it's uneven. I mean, it's normal, but it's uneven or high in Hashimoto. That's autoimmune. The Quervains is low uptake. If you wanted to do a PET scan next, you could. And that shows diffuse uptake. But we never stick a needle in a nodule until we do that radioactive iodine uptake, because we want to know which one's reacting and which one's not. Fine needle aspiration is a biopsy with sent for cytology, and you have to do that to rule out cancer. So if you don't have uptake in some nodules, those are called cold nodules. You want to put a needle in it because that's a cancer until you know it. The hot nodules probably hyperthyroid. So the ones that are actually uptaking that magnesium or whatever you're using, or element you're using. How do you get through? You go for oxygen. If hypothyroid, it's synthroid. Synthetic T4. If you're hyperthyroid, it's propranolol and what we call thiourea drugs. What is it propranolol for?
Slow heart rate.
It's beta blocker used in this case for tachycardia, heart palpitations. Somebody that's hyperthyroid is going to complain that their heart's coming out of their chest. Propranolol is for thyrotoxic symptoms. So that's your tachycardia, your tremors, your sweating, feeling of panic or anxiety. Propranolol calms that thing. Thiourea drugs, there's two, metimazole or tapazole or PTU, which is propylthiouracil. Here's your clue. P for pregnancy. First trimester, P for pregnancy, PT. That's the drug you use in first trimester. Then you move to metimazole. First trimester of pregnancy only. Or you're challenging fertility and you want to become pregnant, it's continue. And in the first trimester, you switch to metimazole or tapazole. Problem with PTU, 25 years old, there's liver dysfunction. That's the only thing safe in pregnancy in that first trimester. No idea if it's ultrasound guided. I'm not sure how I don't know if it's. So if you're doing a breast biopsy and you're looking for, there's a breast mass and it's going to take, it's stereotypical. I mentioned this. Okay. People subacute thyroiditis, your quarter veins. Your first line treatment is NSAIDs or aspirin. Aspirin could be 325 to 650. That's for that pain. NSAIDs could be a higher dose, 600 to 800 milligrams. Prednisone might be needed for that localized anterior neck pain. Painful. If they're not responding to NSAIDs or aspirin, and then for your thyrotoxic symptoms of palpitations, tachycardia, sweating, nervousness, anxiety, or panic. And it doesn't have to be a big walking dose of beta blocker, just enough to make it fun. There's a life-threatening, immediate life-threatening condition with hypothyroidism called myxedema crisis. And that's usually an elderly female. And it can just, something precipitated, there's some event that knocked them into this crisis, because they were already hypothyroid to begin with. They're a little bit older, something happened, did you have heart failure, now you're in crisis? Did you have a stroke? Were you hypothermic? Do you have an infection, and the biggest infection is pneumonia? Zero. Oh, I'm sorry, thank you. Rolling along. Your treatments, yeah. Postpartum. Selenium, believe it or not, 200 milligrams of selenium daily to reduce those autoantibodies against self. I'll let you have a subscription for that. Hyperthyroiditis, IND, that abscess. And then you probably have to remove the thing.
I don't know if you already covered this or not. Pregnant, female with hypothyroidism or concern for child considered. You treat that.
Now, later in life, will that child become hypothyroid later in life? Perhaps. Well, right there as a newborn, you're not gonna affect it. Synthroid's very safe. If you're doing one way. You is safe in the first trimester. Yep. I'd be really bothered. All of those. And then anything that's dealing with, IgG and later. Believe it or not, tamoxifen is the drug of choice. And tamoxifen is going to be very long standing treatment. It isn't just a couple of months. It's going to be very, very long standing. Because a lot of times the gland is huge. There's be some surgical debulking or surgical compression of that because think of the structures surrounding that. You've got your carotids, recurrent laryngeal nerves. What do they do? What cranial nerve is that? Down, you back up on itself. You all go down the vagus, then you back up. Recurrent laryngeal nerve, if we disturb one of those, you guys are going to be hoarse. If we clip one, you're going to lose your range of voice. You're going to be talking different the rest of your life. What happens if we cut both of them? You just lost your ventilation. You don't on the same. It's very, very careful. So in these related thyroiditis, cervical depression is really huge because they're compressing all the structures in that neck. And everything's really, really tight. Now, sorry. Older women with predisposing conditions and hypothyroidism, that predisposing condition that got out of control, there's an exacerbation of the condition. Cause that person to go into crisis with a hypothyroidism. So realize in the elderly, the creatinine clearance is way different than yours. Meds hang around a lot longer, they're not metabolized well. Drug metabolism is even slower in hypothyroidism. So what are the triggers? Sedating meds, hypnotics, anti-seizure medications, opioids, sedatives, anything that's antidepressant, anything that slows it even more so. So they go from being confused to very, very quiet to coma pretty quickly. Very cold. Very, very few respirations. Sodium starts falling. Their oxygen saturation is falling. They're hypoventilating, but they're hypercapnic, hypotensive. You might be predisposing them for acute kidney injury and rapid. So everything happens really fast and the body's just shutting down and shutting down. So hypothyroidism already, they've got a precipitating event that made the hypothyroid condition go out of control. And that's what myxedemic crisis is, and it leads to myxedemic coma, which is that. So you jump on this, treat immediately, and you need Synthroid IVs, immediately. We'll take a little bit of a break before we go the opposite direction of hyperthyroidism. I can tell you all are having a great time with this. It's tough. But endo is hard. You can break it down into, gee, all hypo is like this. What's the presentation that makes it so different? Who's more likely to have it? And what blood lab is doing? Maybe. Let's give you a 10-minute break. Urology, if you know half, you'll know the other half. So if I know if somebody's hyper, I know what they're gonna have hypo, it's opposite. You know, if I know someone's got Cushing's and adrenal disease, and I know what the opposite's gonna be is reactive. If I know someone's got hyperparathyroidism, if we do surgery, I know I'm gonna dump them into hypoparathyroidism. So if I know what one half, what they look like and how they act and other symptoms are, if they're hypo, the opposite things to do when they're hypo. We just did hypo, so now we're doing thyrotoxicosis, which is fancy name for hyperthyroidism. Elevated T4, elevated T3, way too much excess for that. So we have three big attacks. Graves' disease, you've heard of Graves' disease, and that's the most common form of hyperthyroidism. We've got toxic multinodular goiter, which is also called Plummer disease. There's no B in that plumber. There's a finger house. And then there's thyroid storm. So myxedemic crisis is the hypothyroidism, is thyroid storm is the hypothyroidism. Does that make sense? So when you, Graves' disease, look for family history. Someone had Hashimoto's in family, somebody may have Graves in family. Think of females 20 to 40 years of age. Females, but maybe females. But there's a family history of a hypo or a hyperthyroidism. Again, body's attacking itself. It's autoimmune. So for some reason, the autoimmunity body's attacking that gland. There's an increased synthesis of your T4 and T3 because of your antibodies. There's antibodies in hyperthyroidism. And then the thymus gland is also enlarged. So that's concerning. In toxic multinodular goiter, you've got thyroid nodules, and it can be just one, but you've got an autonomous hyperfunctioning nodule that's causing the hyperthyroidism. So it's dumping its T4 and T3. It's constantly secreting, constantly. That's iodine deficient patients. It's older patients, but they risk developing a cancer. Remember, so it's a hyper-functioning nodule. Hyper-functioning, it's a hot nodule. Could be cancer. Could just be hyperthyroidism. You've got to be careful with it. Yes. That I didn't. The thyroid storm is severe crisis. It's typically caused by any of them. Life-threatening cardiac failure. You've got severe sinus tachycardia, like ventricular fibrillation. cardiogenic shock, MIs, liver failure, dehydration, diarrhea. What's pyrexia? Fever. Fever. Thyroid storm. So you know how a hypothyroid patient presents. They're sluggish, they've gained weight, they sleep all the time, they're depressed, they're irritable, they're constipated, they're cold. Complete opposite with hypothyroids. They eat 13 donuts and they lose 10 pounds today. They're heart is racing all the time. Heart palpitations, even at night trying to sleep, they feel like their heart's racing out of their chest. Sweaty, moist, warm skin, probably a goiter, probably some lid lag. Reflexes are hyperactive. Looks, it might have atrial fibrillation too. In Graves' disease, most patients will have a palpable goiter. Only in Graves' disease will you see exophthalmos and preteriousally edema. What is exophthalmos? Thyroid eye disease, looks like the angry chihuahua, the eyes are, why is that? Why is-
Oh, I'm not.
Did you say inflammation? Because you're.
Okay, I heard that.
Inflammation within the globes, inflammation behind the globes, pressing that globe outward. Lid lag, because a lot of times our eyelids can't close all the way. But there's some lid lag that goes on. Creatinine, it's hyaluronic acid deposits on the skin. And it's usually seen on the shins. It's kind of a reddish brownish color, like if your heme is breaking down. And that protein, that heme, hyaluronic acid is what it is. Only do you see these. Like you can look at the skin discoloration. Exophthalmos, lobes jutting forward and they're very large because they're inflamed. Only in Graves. Palpable goiter, most often in Graves. Diarrhea, can't sleep. Diarrhea. Hyperthyroid, T4, pre-T4, T3, T4 could be normal, it could be high. T3 is gonna be high, TSH is gonna be suppressed. It'll be low. This is why you want a T3, because if your free T4 is normal, you go, I'm not really sure right here. Make sure you get the whole panel. Some places only get a TSH and they just, based on what the TSH is, aren't you missing some of the markers? You don't know what's really going on. And then you might have some antibodies against self. Subclinical hyperthyroidism, your TSH is low, your 3T4 and T3 are both normal. That's subclinical. That's how people kind of fly under the radar. One level's not right, the other's kind of are, oh, you're fine. Treat the patient, not necessarily those lab values. Always want an ultrasound. You got this big goiter, gotta get an ultrasound. Whether you felt nodules or not, you got a big gland. So you went to your radioisotope or radioactive iodine uptake scanning, but we don't do that in pregnancy, and we don't do it if someone's breastfeeding. Not good. In Graves' disease, you have increased or normal radioactive iodine uptake. If you've got thyroiditis, which is your hypothyroidism, you have low uptake. And then for nodules, bimanual aspiration, biopsy and cytology is a must. For panel for those thyrotoxic syndromes, the tachycardia, the diaphoresis, feeling like I'm gonna just come in on my skin. Hyperactive, there's 0 to 60 and a half a second, super angry all the time. Their body isn't shutting down. Hyper. Diarrhea drugs, metimazole, propylthiouracil. Metimazole, but not until second trimester if you're pregnant. Continue first trimester or if you're seeking pregnancy. Lots of people once they have an overactive thyroid, they want to get rid of that thyroid gland. They're like, well, why don't we just calm it down? Well, you certainly can. You can do a few things. Radioactive iodines is iodine 131. It's very common. Lots of people do the radioactive iodine. They go to a center. They're gonna leave your clothes, your books, and everything behind because everything's gonna be radioactive, and you get this iodine. However, they inject this into you, and you're radioactive. And they actually have a Geiger counter, but your clothes are radioactive, and the book that you're gonna read, and the TV that you watch, everything that's in that room is radioactive. So however they inject it to you, I think it's based, I wanna say it's based on the weight of, they somehow correlate the imaging studies with the weight of that thyroid gland itself, and that's how much they know how much to give you. And stay in the center. I know animals stay for a week. Like cats have a lot of this. People, I think, stay for 3 to 5 days. I'm trying to remember how long people stay. And you leave everything behind and you leave, not radioactive anymore. You urinate a lot of that out. You eliminate, you defecate it out. And it makes that thyroid cease to exist, basically. So what do you do after you basically kill off somebody's thyroid? You keep this in because they don't have anything to do. So you're gonna dump them into hypothyroid. We do not do radioactive iodine in pregnancy. Don't do it in the breastfeeding kids. Thyroid surgery, this should be a bullet point, sorry, this should be on this one. If that thyroid surgery doesn't come out radioactive iodine, you do one of the other. If you want to remove, because why do you want to remove this? Because the goiter is too big. It's pushing on other structures. It's causing other problems. It's giant. I walk to Walmart, everybody's staring at me because it's so huge. I've seen huge goiters. But you definitely want this if you've got nodules that are suspicious for cancer. Or you've got a biopsy that proved it was a cancer. Or you've got an asymmetric, we could do a subtotal thyroidectomy. We just take one low, leave the other one functional. If you're wanting to plan a family, we can remove that thyroid gland 6 months before you become pregnant. We can certainly do that. If you cannot take Tapazole or PTU. But when we remove your thyroid gland, what's attached to the thyroids? The parathyroids, there's 4 of them. Some people will have 5, they're overachievers. Most people have 4. And they just look like a glob of fat. But they function autonomously. If we happen to finally remove something like, oh, we want to make sure that if we remove, we're going to take that's going to be the gland. We'll tag it, we'll put it in the sternocleidomastoid and put a silk tie on it. To let other surgeons know that's the parathyroid gland, and it just starts functioning by itself. You have to have one of those glands. We lose all 4 without a fail, so you have to have one. So we're very careful when we remove your thyroid that we don't take all of your parathyroids too. And you already told me your parathyroid glands help regulate your calcium in your body. So if we take your thyroid gland, we're also going to keep looking at your calcium. So thyroids and parathyroid glands are not we don't remove them as an outpatient surgery. You're going to spend the payments because we have to keep looking at your calcium levels. You're at risk of tetany. What is tetany?
Lockjaw.
Lockjaw, sees up to lose your airway. So we always have to look at your calcium levels for a few days because of hypoparathyroidism. All right. When did we enrich you? Thyroid storm, thyroid crisis, thyroidectomy, atrial fibrillation, tachycardia, severe tachycardia. But causes your hypothyroidism is caused by somebody, one of these things. A new onset arrhythmia, you never had an arrhythmia before, and all of a sudden, you got one. Check the thyroid function panel. And then thyroid disease. There's commercials all over TV now about this. The one woman that's always wearing sunglasses, she's got thyroiditis. So now it's a real thing. They have dry eye. They can't close their eyes at night. You can wear a mask. at night, you could take your lid shut at night, because the eyelids don't cover the globe anymore because of the inflammation. So protect the corneas. Artificial tears, because they have, what's the form of dry eye? There's four forms of conjunctivitis. Which one is the dry eye? What's the fancy term?
I think so.
Pericardial conjunctivitis. Good. Refer them to an ophthalmologist, but here we go again, selenium helps. Methylprednisolone helps, but only in the IV form. Monoclonal antibodies, and I think that commercial that's on TV lately is monoclonal antibodies. So only in graves do you see exophthalmos, mixedema, and usually big void in hyperthyroidism. Palpated nodules, now what? The appropriate HM. Palpable nodules, multinodular goiter. You'll see them. Rest assured, and you can always tell your patient, most of these, the majority of these are benign. That's a weird percentage. 87% of them don't say no. But most are benign. When we find a nodule, usually it's hyperthyroidism. If it's larger than a centimeter, a golf ball is about 2.5 centimeters, so it's a little bit smaller than that. If it's adherent to the skin, if it's adherent to a structure, if that person's hoarse, it's quick to grow, those are suspicious things for malignancy. Just like anything in ENT, squamous cell carcinomas, these are all suspicious for malignancy. Anytime you used to have a nodule, you got to rule out cancer. You have to. Thyroid function test after the appropriate H&P. Imaging study of choice. First, you start with the ultrasound. Then you do your radioactive iodine uptake. Then you do your finding aspiration, biopsy, and cytology. And then we go to surgery in order to that plan. So TSH is what you want to use for your initial evaluation. Is it elevated? Is it normal? Is it low? The neck, they call it a neck ultrasound in the textbook, thyroid neck ultrasound, because you want to see how extensive is it and where are all those nodules? Because when you actually do a fine needle aspiration biopsy, it's ultrasound guided. So if you're young, if you're male, that's worrisome for cancer. If on ultrasound, there's microcalcifications within it, or punctate little, looks like stippling, those are calcifications, it's worrisome for cancer. If it's solid, there's no echo, lack of echogenicity or hypoechoic. Irregular margins, sometimes I'll say spiculated, like little arms are sticking out of it. It's worrisome for cancer. If you gave them Synthroid and those nodules actually grew, that's could be a malignancy. If you look at a serum calcitonin level and it's elevated, that's worrisome for malignancy. So if your thyroid stimulating hormone is low, let's do the radio iodine. It's called thyroid scintigraphy. Let's go tag these things and see if they're hard. Let me do the biopsy. So make this little chart. History physical. Do the TSH and the thyroid ultrasound. If it's normal, TSH is normal. Let's go ahead and stick a needle in that nodule. If it's high, let's get your 3T4 and your autoantibodies. If it's low TSH, let's get your T3, let's get your 3T4, let's do your thyroid scan. If it's hot, treat them for hyperthyroidism. If it's cold, let's go get a biopsy and let's go get a surgeon. It's cancer, you gotta roll it down. Makes sense. There are three types. It's actually 4 types of cancer. One's a subtype, yes, a subtype. Differentiated thyroid cancer is papillary and follicular. papillary is the most common form of thyroid cancer. It's also the least aggressive. Very survivable, extremely survivable. Follicular carcinoma is part of the differentiated thyroid carcinomas, and it's just a little more aggressive, not much more, probably more aggressive. Medullary thyroid cancer is associated with medullary endocrine neoplasia type 2 syndromes. There's 4 different forms of that. When you see men 1, men 2, men 3, men 4, multiple, not medullary, multiple endocrine neoplasia syndromes have multiple glands involved. Like men 1, and we'll talk about this next time. Men 1 is the 3-piece pituitary gland, the parathyroid glands, and the pancreas, pancreas. Men 2 have another association with it. So this medullary thyroid cancer is associated with that. Less elevated serum calcitonin. Anaplastic is the worst one. It's the worst prognosis. It's the most aggressive. And when they find it, your chances of survival is pretty low. So I think it's 1 year survival is less than 5%. I believe is what it is. It's pretty more likely to be pretty advanced by the time it's found. So thyroid cancer, 53,000 people in the United States annually. In the study, look at that history of head and neck irradiation as a child. That's a big thing. Possible. Some people don't think so, and they just don't remember. Family history of the same thing. When cancer, believe it or not, your thyroid function tests, sometimes you're just normal. But you gotta do your fine needle aspiration cytology. If it's positive, there's your cancer. Some people do complain of neck discomfort, difficulty swallowing, ear pain, because of the way your muscles are, they go right up this direction. Hoarseness, alcohol, lymph nodes, so feelings. A lot of people are just asymptomatic. They never knew they had it. And someone said, hey, got a bump in your neck. You might want to go get that checked out. Because you can see it. You don't see it. So with thyroid cancer, your thyroid function panel may be normal. But if it's a big tumor burden, that is really highly functioning, then you're going to have hyperthyroidism. Image the neck, ultrasound, radioactive iodine update, scintigraphy. Here it's going to MRI is better than a CT. If you go and start with a CT, because at that point you're going to check for metastasis. And where do thyroid cancers have to metastasize to? Lymph nodes, bone, and lungs. So you reserve a PET scan to see where else this cancer is disseminated to. If your uptake on your radioactive iodine is showing, that's what this PET scan is reserved for. Frequent choice, of course, is we're going to remove the gland. That everybody wants this thing out. Get it out. Take it out. We're going to make you hypothyroid. Got to be performed in the patient, because what I said before, you're probably gonna snag some of those parathyroid glands with it. So we worry about lack of calcium, the lack of parathyroid hormone that regulates your calcium. So we worry about tetany. So hypocalcemia is tetany. We worry about recurrent laryngeal nerve injury. That's bad, because it could take your respiratory drive to breathe away. We worry about a hematoma, like a little bleeder. One little vessel we didn't clip really well, and it's bleeding. Now we've got this big hematoma in your neck. When we do thyroid surgery or parathyroid surgery, we actually follow the line at the bottom of your neck, the most inferior portion of your neck, and basically make it Pez dispenser. Just lay your supine on the table, pillow, a whole bunch of rolls of towels by your shoulders, so that your neck, your head is this way, your body's this way, so your neck is jutting out. Slice from here to here, and then we do one long cutaneous suture. So with a knot on either end, subcutaneous suture, so that if you did have a hematoma or bleeder, and it's in the middle of the night, and you're the PA who's on call, you clip a knot, hold the suture out, and release that clot. We miss that movie for that surgery. That's the reason why. We don't staple them shut, we don't glue them shut, we don't continuous, you don't have time to pluck out all the sutures. It's one out. So there are problems that do happen after surgery. Airway compromise is a big problem. You worry about that with TED, you worry about that with a hematoma, you worry about that compression on those structures. So it's not done ambulatory, it's done, you're gonna spend the night in the hospital for about 3 nights. If you have thyroid carcinoma and you're pregnant, they're gonna wait till you deliver the child, unless that tumor is really fast growing. If that's the case, then they take that after week 24. So, is there residual thyroid tissue left behind? Sometimes we can peel off that trachea. If there's anything residual left behind, then they're gonna do some post-operative radioiodine, but I won't remove. If the rest of the residual tissue, if there's any. But every year, you need an annual thyroid ultrasound and a serum thyroglobulin level. While you're taking some, because maybe you hypothyroid, so you need some. Just to make sure that cancer doesn't come back and believe it or not. If recurrence happens, it happens 5 to 10 years after you remove that cancer. Okay, so 1 year survival rate for anaplastic is 10%, but 5-year survival rate is 5%. For anaplastic. So you get these parathyroids. So you hyperparathyroidism, hypoparathyroidism, and hyperparathyroidism. It's cycle. So we have primary, secondary, tertiary forms. Primary is with the parathyroid glands themselves. Secondary is with the pituitary gland. Tertiary is with the hypothalamus. So biochemical markers now. PTH, parathyroid hormone, used to call it parathormone. Was it ever that way, Professor White, when you were in school? Parathormone. Parathyroid hormone. Intact parathyroid hormone is IPTH. Serum calcium, serum magnesium, they go hand in hand. Parathyroid glands are affected by magnesium in your bodies. So if there's too much magnesium or too little magnesium, your calcium may be adversely affected and make it too low. Why is that? Anybody know? Magnesium suppresses the action or secretion of calcium from the, it suppresses the action of secretion of parathyroid hormone from the parathyroid gland. So if you have too much mag, it's a bad thing, you have too little. Also, when we take a parathyroid gland with ionized calcium, we'll certainly put ionized calcium in it. So ionized calcium and intact parathyroid hormones, some hospitals have them, some don't. So primary hyperparathyroidism is a hypersecretion of parathyroid hormone, usually by a single adrenal, and that's about 85% of the time. So you've got 2 on the posterior sides of even lobe. 1 is overdoing it. What do the other 3 do? If one's overdoing, oversecreting, what do your other 3 guys do? They also. So the analogy I use for that is, and this guy's just overdoing it for the rest of his policy. The reason why we keep you post-surgery is because those things have to wake up. Wake up, wake up. The analogy I'll use is a grandparent. What is their favorite dinner time conversation?
You have a boyfriend.
Family kids, right?
Oh,
How many families do they have?
I said, if you.
And they'll say, but I want to laxative and I got them. What are they doing to their bodies? They're overstimulating their bodies. So we take those enemas and laxatives away, they're constipated. That's the same thing that happens with your parathyroid glands. If you've got one hyper-functioning adenoma, it's doing all the work for all 4. The other 3 are just going to go to sleep. Hey, you're working for me. I'm just going to be lazy. I'm just going to hang back. Usually we find this incidentally. How in the world do you find this? You're female in your 70s and you go get your annual blood work done and someone says, oh my gosh, your calcium is 16. Calcium should be like, what, 8.5 to 10.5, something like that. 16. Do it again. Let's redraw that. Make sure that. Have kidney stones? Depressed? Are you constipated? Your bones hurt? No, I know. I never looked this up before work again. Oh, it's 16.2. We have an issue. We might have hyperparathyroidism. That's not normal. That's the incidental finding on this annual blood labs. That would be indicative of primary hyperparathyroidism. So women that are in their mid-70s, typically when we find this. If there are symptoms, people don't know they have it. But if there are symptoms, that I gave you the mnemonic: bone stones, abdominal groans, psychic bones, fatigue overtones. Bony pain. If the parathyroid hormone is leaching calcium out of the bones, it's putting it in the circulating bloodstream, your bones are going to hurt. You're going to get osteopenic and not osteoporotic. Kidney stones. Circulating calcium's got to go through the kidneys. So now I'm jamming it up with calcium, and that's a kidney stone. That's painful. Calcium channels in the gut slow peristalsis so that you can break down all the food that you're eating into simple molecules to digest, and calcium channels slow that. Because you have extra calcium in the bloodstream, and now you're constipated because you're too slow and too sluggish. You're not peristalsing the way you should be. Heart conduction can be affected too as calcium channels in the heart. Psychic bones, typically depressed and exhausted. People are exhausted all the time. Many people don't have those symptoms. But if you have those symptoms, it's time for that hyperfunction analytic. So your diagnosis is confirmed by your hypercalcemia, plus look at the level of your intact parathyroid hormone. If it's elevated and you're hypercalcemic, there's your answer. You have primary hyperparathyroidism. We can look at urine calcium, we can look at urine phosphate, that'll be high, we can look at serum phosphate, it'll be low to normal. Alk phos is normal high. If you have a child and your alk phos is high, what does that mean? Is that a bad thing? It's a normal thing because their long bones are growing. Forehead's widening, their long bones are growing. Alk phos is normal, high normal in the kid. What about adults? Alk phos high, not a thing. You have cancer, or this condition, something's wrong. Imaging is not necessary unless you're going to go to surgery. So there's medications we can use, or if it's your serum calcium, it should be below 10 points. It was 8.6, 10.4, I think, something like that. You're 11. Let's just keep an eye on you. Watchful waiting. Let's look at your blood labs in another 6 months. Let's make sure. Let's get a DEXA scan. Make sure that you're not losing your bone density. 75 years old, you're losing your bone density. But we don't want opportunistic fractures. If you're going to go to surgery, and ears, nose, and throat, and ENT, did they professor what you do your thyroid surgeries or thyroid surgeries? We did a lot. I worked for a California. Ultrasound or system maybe scanning, so we know exactly which one is the hyperfunctioning one. But there are secondary and tertiary forms of the condition. So secondary hyperparathyroidism is usually caused by chronic kidney disease, but it can also be caused by inadequate calcium, inadequate vitamin D, and inadequate intake or absorption or malabsorption issues. And then tertiary hyperparathyroidism is an autonomous secretion of the parathyroid hormone because of long-standing chronic kidney disease, long-standing secondary hyperparathyroidism, long-standing issues with calcium absorption, calcium intake, vitamin D intake. So when we see people with calcium problems, do you have enough circulating vitamin D? Vitamin D goes in outside for 20 minutes, you got all vitamin D you need because you have to have that absorbed calcium. You gotta have that. It's mineral homeostasis, mineral metabolism is part of your kidney function. You only absorb so much at one time. I can't remember when I was doing some renal with Dr. Gazelle last semester. You know, people take those vitamin packs, like, oh, look at this one little cellophane thing, it's got 27 vitamins. And then you've got this glow in the dark urine for the next 2 or 3 hours. Why is that? You can only absorb so much at one time. And your body's unlimited. You have very expensive urine. So your body can only absorb so much. So take that packet of vitamins that are probably really good for you, split it into three parts and just take it every 8 hours. Your body can't absorb that much. And that's what happens in the neural homeostasis. That's part of your kidneys, that's part of the vitamin D, it's part of your calcium. So always check D and calcium levels. So the treatment, surgical excision of that one hyperfunction in that moment. Yeah, the majority of the time it's going to be anything, 87% of the time. It's not going to be cancer. So you know what parathyroidectomy. Some people that are asymptomatic just say, I just want to be on medications, let's watch and wait, don't have to deal with it. Okay. That's your call, as long as you're not having symptoms from it, that's fine. But if you've got these debilitating symptoms and you're at calcium stone form, you're constantly going to calcium, kidney stones, and you're constantly chronically constipated, you're tired of feeling sick and tired all the time, your bones hurt, okay, let's go to surgery. So non-surgical treatments, let's hydrate you. Now, be very careful in heart failure, don't overdo it, because you'll fluid overload sometimes. But IV fluids, unless contraindicated. Contraindicated would be chronic kidney disease, end-stage renal disease, heart failure. Calcium sensitive receptor activators. They're also called calcium mimetics. So you can give that kind of medication. Cincalop is one of those. Bisphosphonates like Believa, we used to hear Believa all the time. Reclass is a popular one. Fosamax is a very popular one. I don't know if Dr. Noel's gotten into those medications yet, has he? Okay, I'll tell you how to take them. Some of you have to take sitting straight up. You can't go down for an hour or so after you take it. And then Prolia, if you got parathyroid cancer. Questions on hyperparathyroidism? Go the other direction. We remove that hyperfunction atom, and now we put you into hypoparathyroidism for that reason. That one was overdoing it. For the other 3, we've got to wake those other 3 up. Wake up. You guys got to start working again. Until you wake up, and it takes a couple of days, you are hypoparathyroid. Pseudo hypoparathyroidism is a congenital issue. It's hypocalcemia because the body's resistant to parathyroid. That's all that pseudo hypoparathyroidism means. So hypoparathyroidism, your calcium is low, so you have hypocalcemia. Your parathyroid hormone level is low, your serum phosphorus is high, your alpha phosphorus is normal, your excretion of calcium is low. So your hallmark of hypocalcemia is tetany, it's airway complex, lockjaw, disease. So tetany is a neuromuscular disorder. And what you worry about, especially after these surgeries, or anybody that has low circulating serum calcium, their fingertips tingle, their toes tingle, their calves cramp, around their mouth and their tongue tingles. You have these patients with surgery, and fingers tingling, yeah, a little bit. Calves cramping, no, but my mouth, around my mouth, it sure tingles, and it's weird feeling. Feels like I have no pain, and my tongue's starting to go. Oh, you don't have calcium. Carpal tunnel spasm or laryngospasm, seizures. Don't want to get to that point. So here's 2 tricks, 2 bedside tricks. Dropsip sign. If you have low circulating serum calcium, tap on the zygomatic arch of that patient. Tap, 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 tap. After about 30 seconds of tapping, it starts a neuromuscular excitability and it'll spasm by itself. That's low circulating serum calcium. So that's a positive Dropsip sign. Trousseau phenomenon. Wrap a blood pressure cuff on their upper arm and inflate it 30 above what the normal systolic would be. Their arm will start flapping all by itself. It'll start spasming on its own. That's Trousseau phenomenon. That's low circulating serum calcium, so hypocalcemia, 2 bedside checks. For this one, this is irritating, enough, it's just normal. But you do it to people and it'll spasm by itself. It's really interesting, just do it and see what people do. So what do we do? Best trial. Calcium carbonate. Is calcium carbonate vitamins? Do we know? Vitamin D. You're not gonna absorb your calcium, you don't have vitamin D. And then you've got to correct the hypomagnesemia. If you have too much mag, or if you have too little mag, it keeps parathyroid hormone either from secreting or doing its work. And you'll have low calcium. So you have to adjust. You've got to give calcium. So for maintenance, calcium carbonate and vitamin D. And always watch the mag. Always, always watch. No. Questions? I'll talk to him in a nice stepwise fashion. And again, as with everything endocrine, if you know something that's hypofunctioning and how people react when it's hypofunctioning, you'll know what happens when it's hypofunctioning. And how they look and how they react. All right. So once again, we've got a primary disorder or a secondary disorder in independence. Primary means the gland itself is the issue. So in hypothyroidism is primary, is autoimmune destructive thyroidism. That's all we need. Secondary means it's the pituitary gland. Tertiary can be the hypothalamus, but it's not, the gland's doing what it's supposed to do, but it's not getting any signal from the pituitary gland. So in Cushing disease, and we'll talk about that. In Cushing disease, there's a hyperfunctioning pituitary adenoma that's oversecreting adrenocorticotropic hormone. So the adrenal gland is making way too much cortisones. Cortisones are stress hormone. You have tertiary issues, but there's probably something going on with the hypothalamus, like brain tumor, or something else. Your hypothalamus fails to secrete anything that stimulates those adrenals, so pituitary just doesn't do anything. That's tertiary disorder. So just kind of to keep that in mind. In adrenocortical hypofunction, your adrenal cortex, the adrenal glands sit on top, the superior pole of your kidney. You've got 2 of them. Adrenal cortex doesn't produce enough of the hormones, and they're steroid hormones, cortisol and aldosterone. So Addison's disease is one of them. Primary adrenal insufficiency, which is basically what Addison's is. You have secondary adrenal insufficiency because you're not secreting adrenal corticotropic hormone. There's forms of adrenocortical hypofunction. So when you're in the comments, you add that definition. That's what this means. So what is aldosterone? So we have aldosteronism. It's a mineral corticoid, is what it's called. And it's produced by the adrenal cortex. So it's part of the renin, angiotensin, aldosterone system. Nice little biofeedback loop that works really, really well to perfuse the kidneys to help get that heart going. And when your kidneys are, the renal arteries are stenosed and you're not perfusing the kidneys like you're supposed to, the renin, angiotensin, aldosterone system really kicks in. And what does it do? It wants to perfuse the kidneys because the kidneys actually make the heart function. It's going to perfuse the kidneys so it bumps up the blood pressure to the kidneys to make the heart more active. Keep the heart going. Get the cardiac output the way it's supposed to go. How does it bump up the blood pressure? That sounds like a nice segue. It holds on to fluid. That's why people with heart failure get edematous. They're full of fluid, cephalic, goes up toward the head. Everything is a whiteout. Holding on to fluid to get that blood pressure to pump up to perfuse the kidneys to make the heart function properly. So that's the renin-angiotensin aldosterone system. When you're healthy, it works great. When you're not healthy, it really works against you, but it's trying to keep you alive. So aldosterone is part of that. It controls sodium and water balance in the body. It controls sodium and water in those kidneys. So it's going to retain sodium and water, but it's going to flush out that potassium. You have antidiuretic hormone. Think about that. It increases your water absorption, reabsorption, while aldosterone increases salt absorption. Too much aldosterone causes too much sodium retention, causes fluid buildup, causes hypertension. And you're excreting too much potassium and you're suppressing the renin. So that's how that system works. But in aldosteronism, things kind of go awry. So hyperaldosteronism is primary aldosteronism. It's renin dependent. You've got way too much aldosterone and you can't suppress it. You've got way too much being secreted by the adrenal glands. You've got way too much of a good thing. You'll see an increase in cardiovascular events because of this. The potassium on the channels in your cardiac process. Yeah. So you've got two things that can happen. You can have adenomas that are hyperfunction on both adrenal glands, or you can have just one adrenal gland with a hyperfunction adenoma. That's called Clin syndrome. So bilateral adrenal cortical hyperplasia, more men than women, over 56 years of age. If it's just one hyperfunction on one adrenal cortex, it's usually females and they're a little bit younger, 30 to 50 years. So if you think about aldosteronism in the general population, it happens. And peak incidence, it sounds silly, 30 to 60 years of age, we put them both together. But Clin syndrome, if you hear that, think female. In primary aldosteronism, it's refractory. It's often the culprit in refractory hypertension in somebody who's very young or they're middle aged. If you have hypertension when you're really young, there's something going on with the adrenal gland, person you want to do about. You worry about it. In your textbook, it's got two different places. Worry about primary aldosteronism if someone's had a stroke before the age of 50, and then somewhere else in the book further up. Worry about it if they had a stroke before the age of 40. Your incidence of stroke goes up after 45. I'd worry about it if you had a stroke before the age of 40. Something's wrong. Hypertension can be moderate, severe, and sometimes only the diastolic number is the one that's high. Remember, diastolics that return. Sometimes that's the number that's way too high. So we're about things that are over 150, over 110. That's huge. Where's your stroke? Where do you worry about an ischemic stroke converting to a hemorrhagic stroke? What's the pressure? 180 over 110. So now we're worried about primary aldosteronism if it's above 150 over 110. So that's where that stroke thing comes from. That's that criteria. Way too much aldosterone. Remember what aldosterone does. Talking to those kidneys, hold on to sodium, hold on to fluid. I'm going to dump this potassium. Don't need so much. If you have way too much aldosterone, then you don't have enough potassium, and that's cardiac function. So you have hypokalemia, muscle weakness, too thirsty. You're dehydrating yourself. You're losing all your urine. You're not a with this. So let's test for people. Remember, hypertension, there's seven or eight criteria. 1, 2, 3, 4, 5, 6, 7, 8 criteria. The same hypertension is greater than 150 over 110. Especially if you're young. Your middle age, something's wrong. It's refractory to your meds. Or you're resistant to 3 conventional antihypertensive drugs, and one of those was a diuretic, and we still can't control you. or you're on 4 or more antihypertensive meds just to get your blood pressure controlled. That's a lot of medications. We talk about a compliance issue. You're losing your potassium, and it's not because you're taking a loop diuretic. It has nothing to do with diuresing you. A loop could be orsamide or Lasix, could be hydrochlorothiazide, a thiazide medication. Your hypokalemia has nothing to do with your diuresis. There's a family history of early onset stroke, early onset hypertension. There's a family history of cardiomyopathy. You have an adrenal mass, or you've got low plasma renin activity. Renin is just an aldosterone. Low renin, aldosterone's not going to do what it's supposed to. Potassium's not going to be there. Low renin activity means my aldosterone's going to go way up because it's trying to work against something that's not working. It's not these nice negative feedback loops. Does that make sense? So any one of those 8 things, consider testing. When it comes to the adrenal glands, everything has to do with the diurnal rhythm, your circadian rhythm. And believe it or not, the way they test for aldosteronism, you've got to be up and out of the bed, not being supine anymore, up and out and moving around 2 hours before the test and sitting down, calming down for at least 15 minutes to an hour before they take that blood draw. You want plasma potassium, not serum potassium, the plasma potassium. Because you want to see a normal value. If that's, a normal value suppresses your aldosterone. Your aldosterone's out of whack. It's way too high. You want to see a normal value of plasma potassium. And then there's something called PCA, plasma aldosterone concentration in a ratio to plasma renin activity. I've looked up probably 8 different, from 8 different sources on this. And the number is always something else. It's greater than 20, that's diagnostic of primary aldosteronism. I've got numbers at 64, 30, but most of them say 20. So I don't know what renin activity numbers. I think it has to do with the units they use for both of these. And then there's a confirmatory lab. So if I do this ratio and my ratio exceeds 20, that's my diagnosis, but there's a confirmatory diagnostic study that you've got to do. And a serum aldosterone, if it's elevated, the renin is suppressed, then it confirms that original diagnosis. Then we go to imaging. An imaging scan of choice, or the first one you're going to try is a CT. Sometimes the hyperfunction adenoma is so tiny, CT won't pick it up. So what do we go to next? MRI. Usually MRI works. If it doesn't, it's MIBG, scintigraphy, whatever, but go CT first, followed by MRI. So remember, you either have hyperfunctioning on both adrenals, or you have a hyperfunctioning adenoma on one. If it's one, it's Conn's disease, it's typically female. We're going to remove the adrenal gland. It's small, it's going to be a lot of fats, very, very tiny. Remove the adrenal gland because you've got the other adrenal gland. You're good. We're not going to remove both. We're going to remove the one. And then we're going to give you long-term blood pressure control. And hopefully we don't have to use so many meds on you. If it's bilateral adrenal hyperplasia, then we need potassium-sparing diuretics and long-term control of your blood pressure. So we need spironolactone, which is potassium-saving. We've heard of potassium wasting, potassium-saving, spironolactone, aldactone. It's potassium-sparing. Maybe a lodipine, maybe an ACE inhibitor, maybe an ARB. What is so important about an ACE inhibitor or an ARB? Yeah, it's very kidney protective, good, very nephroprotective. Secondary aldosteronism, it's because there's an issue somewhere else in the body that causes the adrenal glands to release way too much aldosterone. Something else is going on. Excessive activation, this is the way to think about it. Excessive activation of the renin-angiotensin aldosterone system with high renin, high levels of renin. Maybe it's family history, maybe it's somebody's diet, believe it or not, black licorice. Anise. People like black licorice in here? I love the stuff. When I was getting my doctorate, my mom used to send me a bag of Twizzlers all the time. Hey, that was this big around. I ate so much of that black licorice, I actually pumped my kidneys. So it's true. I actually took my kidneys out. So not knowing, I'm like, why am I so puffy? Why do I have so much fluid overload? It's whatever is in black licorice. I have to look it up again. There's an enzyme in it. Boy, it'll tamper things. Have I had any black licorice since the 20s? No. Never. Never do that again. And that was probably 15 years ago. Never put it on. Left ventricular heart failure, pregnancy, or pulmonary. What's going on? Is it right? Excited heart failure that leads to pulmonary hypertension? Like girl, good. Liver cirrhosis. But if it's renal artery stenosis, remember how that renin-angiotensin-aldosterone system works? Renal arteries are stenosed or narrowed, which means you're not perfusing the kidneys properly, which means it's going to start holding down the fluid to pump up the pressure, perfuse the kidneys to make the heart work. Oh, we got renal artery stenosis. That's probably what's causing secondary aldosteronism. That makes sense? Okay. I found this really good chart last night. Low renin and high aldosterone, primary aldosteronism, that's low renin. High renin is secondary aldosterone. I thought, well, this will help. Don't worry about the stuff in the summer. This is really good. What are the causes of that hypertension? Got too much renin, renal artery stenosis. Ooh, aortic coarctation. Where do you see that? That's beets, right? Coarctation of the aorta. Reninoma. Well, primary, we talked about that. So primary, low renin, running away with that aldosterone. Secondary aldosteronism, high renin. How's that? Remember the mineral corticoids. So Cushing syndrome. Cushing syndrome could be Cushing disease. It's kind of a play on where you find it. Because they look identical. They absolutely look identical. So Cushing disease and Cushing syndrome have everything to do with cortisol, and cortisol is the stress hormone in your body. So as you get older, you can make fun of yourself, say, oh, I'm getting all this weight because I'm stressed out. That's the cortisol over. Well, it could be, certainly could be. So Cushing's is really hypercortisolism. That's the other name for it. Adrenocortical excess, way too much cortisol. Do you know the difference between exogenous and endogenous? Exogenous means we, your provider, are doing something on the outside to make this condition worse. That's exogenous. Endogenous, something inside your body is making this condition worse. So exogenous Cushing syndrome is the most common cause. We're giving you too many steroids. We're giving a patient way too many glucocorticoids. Your COPD exacerbation, and you've got a ton of steroids at home, and they're not effective. We're giving you even more in the hospital. We're making you Cushing away. We're doing it to you. Super physiologic amounts of it. It's exogenous. We're giving you way too much steroid. And we're cranking that cortisol up because of it. Now, endogenously, you've got an oversecretion of glucocorticoids by your glands. So those are your mineral corticoids again. Mineral corticoids, glucocorticoids. We're going to divide it into adrenocorticotropin hormone dependent causes and adrenocorticotropin independent causes, because that's what's going to determine whether you have Cushing syndrome or Cushing disease. They look identical. You can't look at a Cushing person. You don't look at a Cushing person and say a Cushing-like type of body happiness. You know they've got disease or just have no idea. But you're gonna have to find what caused it. So I broke it down even further for you. Endogenously, you could have adrenocorticotropic Corticotropin hormone dependent and independent causes dependent is about 80% of the time. You've got a benign adrenocorticotropin hormones creating pituitary adenoma, that's Cushing's disease. Pituitary adenoma, if it oversecretes adrenocorticotropin hormone, is Cushing's disease. But if it's adrenocorticotropin hormone independent, that's the minority of the cases. And it might be a cortical secreting adrenal adenoma. That's Cushing's syndrome. We're giving you too much steroid, Cushing's syndrome. There's an adrenal adenoma producing too much cortisol, Cushing's syndrome. There's a pituitary adenoma producing too much ACTH, Cushing's disease. Does that make sense? Because they look identical. All right. Every single thing, what is the difference between disease and Cushing's syndrome? Every single thing that could possibly cause somebody to have way too much cortisol in their bloodstream. You take hydrocortisone or prednisone. Are you taking a steroid and something over the counter that you're pumping iron with, and you're taking all the supplements from GNC? Is there something with steroids in there? You don't know it. Are you intentionally taking anabolic steroids for performance? Or is your somatic nervous system activated constantly because of your high stress level in peace? Serious high stress depression, that's peace. And you've ruled all this stuff out, then it's gotta be the pituitary gland. And it's disease. But if it's any of those things you just said, it's syndrome. Hypertension, diabetes type 2, friable skin, easy bruisability, large trunk, fat pads in the face, moon faces there. Supraclavicular fat pads, big fat pad on the back looks like a buffalo. Purple striae on the belly, hirsutism. Friable skin, acne. Very thin lollipop stick arms and legs. Muscle gain, depression. So this is what Cushing's syndrome, this is what Cushing's disease looks like. You can't tell unless you just figure out it came from the pituitary gland or it came from somewhere else. So if we overdo it with steroids, this is a Cushingoid appearance. In a stepwise fashion, here's the test. Step 1. We're going to collect your urine for 24 hours. And we're going to check it for free cortisol. Or, what's even easier, is a late night salivary cortisol test. And if that test comes back high, then we do step 2. One of those 2 steps. Step 1 comes back high, step 2. An overnight dexamethasone suppression test or dexamethasone challenge test. Step 2 could also be looking at your plasma adrenocorticotropin hormone level. Because if that level's high, your pituitary gland is culprit. And then you just, it's Cushing's disease. That's the problem. If it's normal, just the adrenal gland's behaving badly. You've got an adrenal gland problem more than. If you've got a secondary cortisol excess and it's the adrenal gland, then you need an MRI of those adrenal glands. Or we need an MRI of that pituitary gland, and the pituitary gland's the issue. I gotta find out who's at fault. So the way your circadian rhythm goes, if you're gonna identify high cortisol, when is it at its lowest? Because you want to test it when it's at its lowest, and if it's really high, there's your answer. Your most low, it can be in the morning. So that's when you're going to do your test. You're going to spit that little vial and send it in. 3 in the morning. It's highest at 6 in the morning. So if you're trying to identify your cortisol level is too high, you pick the lowest level of your circadian rhythm, and that's when you test. 1 wellness, a prenatal. Sit arm, the spit in a vial. It sounds weird, but that's what she did. Send it to the lab. If it's low as a Cushing's disease. If it's high, do you need to do more testing? Do you want to do your suppression test? You've eliminated all the other outside reasons or sources or conditions that cause Cushing's or hypercortisolism. The most common endocrine reason for excess cortisol is your Cushing disease. That's your pituitary gland issue. Over-secreting ACTH. Cushing disease. Damn.
If they start to get positions in the, like actually taking the surgery, would they still do all of this, or would they just have you stop?
No, they slowly taper. But if you got a patient and they're not your patient, but they came to an emergency room with something wrong, or they were admitted because something's out of control. And, they haven't had a primary care provider for a while, you got to do something. So if they are on the super physiologic amounts of steroid, slowly taper, because you're gonna do the body level, just gotta take them off. Which a lot of patients do themselves, which is not, it kind of brings them to do it. I gotta see that.
Is this done by a PCP or is this work up by an endocrinologist?
Endocrinologist or internal medicine, who would send it to the endocrinologist, it depends on the. This, if you suspect something, you're gonna refer. If you're a PCP, that's gonna be out.
That's what.
But you still need to know what's going to happen. So I get patient education and we can start, I'm gonna go ahead and order this stuff, but I'm gonna have them follow through, but I've already ordered it. And that's a good deal. Remember, Cushing syndrome is not endocrine. Someone's giving them too much steroid, or they're taking too much steroid, they're getting up to too much cortisol. Yeah, small lung cell cancer. Remember, we had these pancreas tumors we talked about back in pulmonology last semester. It just seemed like years ago, but we talked about it. Atopic production of an ACTH tumor, like small lung cell cancer that leads to, that's Cushing syndrome, but if you need Cushing disease, because it'll eventually affect the pituitary. Where's that? All right, here's a big take home. If the cortisol is high, remember when it comes back, step one, if cortisol's high, whether it's urine or salivary, if it comes back high, do a suppression test. If the cortisol comes back low, order a stimulation test. So you're either going to suppress ACTH or you're going to try to stimulate ACTH. That's the big goal. For the tremors. So, how do I manage the patient? If we're giving too many steroids, slowly taper to the right. So slow. Find a different therapy for them. We've made them way too dependent on this and we've caused the issue. Or they've caused the issue. They're taking a supplement. Endogenous Cushing syndrome leads to Cushing disease. When it's Cushing disease, we're going to remove the offending adjuvant. So it's transfemoral resection of the pituitary adjuvant. If it's ectopic, which means it's somewhere else other than the pituitary gland, it's usually the adrenal gland, and you're going to go surgical excision. Sound good? You have an asthma, and you're not on any steroids, and you're all you have is your albuterol inhaler, and Olivia's done everything she can for you. You're not compliant. You're like, okay, put in 60 milligrams of prednisone today, tomorrow, the next day. I don't even take. I just want to hit you with a big whopping dose, so you stop using it. However, if you've got horrible poison ivy, and it's not, mineral dose packets, your poison ivy rashes is laughing at you. Then I might start with 40, 5 days, then I'm going to taper to 20 for 5 more days, and then taper to 10 for 5 more days. So it just depends on what the issue is. Good question. cortisol is high, Cushing's syndrome, or Cushing's disease, or adrenal tumor, or small cell carcinoma, lung cancer. If it's low, it's completely the opposite thing, and that's Addison disease. Addison disease primary is a primary disease. Autoimmune destruction of adrenal glands. Now you've got a cortisol deficiency. So adrenal insufficiency, primary adrenal insufficiency is Addison disease. So remember, if you know what Cushing looks like, the complete opposite thing is what adrenal insufficiency looks like. And primary disease, autoimmune destruction of adrenal glands, is Addison disease. It is uncommon, but you'll see it. Usually females, 30 to 50 years of age. Autoimmune, that's kind of like the word of the day, isn't it? Autoimmune. If it's primary, it's the gland itself. If it's secondary, it's a pituitary adenoma that's suppressing the adrenal cortical release. There's tertiary, you've got something wrong with the hypothalamus. So Addison's, it's adrenal failure. There's another word, autoimmune adrenalitis. Central, which is basically it's everything else outside of the secondary nutrition. Secondary gland, it's the tertiary gland, tertiary, it's hypothalamus, it's hypothalamus. So what's the presentation? What does Cushing's look like? What's the complete opposite thing? Thin, anorexic, muscle wasting, the weak. In Addison disease, realize the adrenals also work on that middle section of the pituitary gland, which deals with your melanocytes. So your pigmentation is going to be affected in primary adrenal insufficiency or Addison's only. So they're going to start looking like they're nice and suntan, and it's dead of winter, February, and blizzard. So the melanocytes are overproducing. So they look, yeah, they kind of a bronze tint to their skin. Starts the buccal membranes, goes into the gingiva, then it's on the creases, you really see on the creases of the palms and soles, and then it's to the rest of the skin. You will not see hyperpigmentation in secondary or tertiary diseases or adrenal insufficiency because it's not your adrenal controlling hormone secretion. It's not increased. This is increased. It's a pituitary issue. Sorry, it's not a pituitary issue. It's not a hypothalamus issue. It's a autoimmune destruction of adrenal glands issue. Step one, check the adrenal glands. Early morning serum cortisol level less than 3. Looks like so it's low. Let's go to step 2. Check the pituitary gland. Do a synthetic challenge. Stimulate it. If there's no response, no cortisol response or low cortisol response, then that's adrenal insufficiency. Then let's CAT scan those adrenal glands again. And the CAT scan doesn't show anything right in our eye. Where are you lowest? 3 in the morning. When is it highest? About 6, 7 o'clock at night. So let's measure it as highest and see if it comes back to normal. So your circadian rhythm has everything to do with cortisol. Realize that primary adrenal insufficiency attacks both the adrenal medulla and the adrenal cortex. And that affects your mineral corticoids, renin and aldosterone. If you confirm adrenal insufficiency, check for renin and aldosterone deficiencies. Hydrocortisone is your treatment of choice. It's not even fluorocortisone. Yeah. That's your treatment of choice, not prednisone. Because it has neurocorticoid properties, not prednisone. They'll need lifelong cortisone. to the point they're gonna have to wear a medical work bracelet. Because if they're ill or they're undergo surgery or they have some kind of precipitated event that stress hormone kicks in, horrible cortisol really overdoes it or underdoes it, they need stress dosing. Or they're gonna die. That's the problem. So glucocorticoid replacement therapy is hydrocortisone, mineral corticoid replacement, aldosterone is also sufficient as glucocortisone, dihydroestrogen, perhaps if you're wanting to have children and it's deficient. And bracelet for life, stress dosing. So illness, your exam next Tuesday. It's exercise, so all the stress dose, then stress dosing. Means hydrocortisone, 100 milligrams IV stat right away. That's gives them a little bump. You have some surgery, we're gonna stress dose you that hydrocortisone. Cortisol dependent especially. Homocytoma. That is a catecholamine secreting tumor that comes from the prolific cells of the adrenal cell. And it makes that patient feel completely out of whack. Everything in it, this blood pressure, heart rate, sweats, I mean, it's pounding headaches. There's a classic triad, episodic headache, sweating tachycardia, and the person feels like they're just crawling out of their skin. Is it a zebra? Yeah, I've seen 2 of them. 2 through the emergency room. It is a zebra, but you always have to keep it your differential. Something's not right. Sustained or paroxysmal hypertension. What does paroxysmal mean? Paroxysmal comes and goes, comes and goes, comes and goes. Hypertension is the most common sign, but let's look for plasma fractionated free metnephrines. Or 24-hour urine catecholamine or metnephrine's confirmation. And then find out what this tumor is. There is a tumor on the adrenal gland somewhere that's causing the body to completely go out of whack. High blood pressure, tachycardia, sweating, headache, heart palpitations. This can kill somebody. Find out where that tumor is, where exactly the adrenal medulla it is, and so size it. But you have to, because their body's already going out of whack, we've got to prepare the patient before surgery, and we have to do it in a special order. We need an alpha blockade and a beta blockade. So I've got your 2 medications listed here. Adrenergic blockade is first, followed by your beta blocker next. And that's one approach to preparing them before they go to surgery. As soon as we take this tumor out, they're gonna take, so, block, so they're blood out of control. It's really hard to do surgery on somebody who's metabolic, very metabolically challenged. Heart rate's too fast, the blood pressure's too high, it's very hard to deal with. All right. I think this is probably the last piece here. First to it, First, it's the virilization. So we're talking about this here. So hirsutism is just cosmetically unacceptable hair growth, terminal hair growth. And it kind of depends on what social norms are, what the ethnicity is, what the cultural norms are. These appear in women in a male pattern. So think of alopecia, male pattern baldness, male alopecia. And things called androgen dependent kinds of issues. So think about this, 5 to 10% of all women of reproductive age, and over 40% of women at some point in their lives have these issues. That's not for women. Virilization is development of male physical characteristics. That's pronounced muscle development, that's a deepening voice, male pattern baldness, menstrual irregularities, acne, severe hirsutism. It could be idiopathic. We don't know why this is being caused. Are you taking a supplement of some kind because you're a bodybuilder? Is it a genetic issue? Do you have polycystic ovary syndrome? Have you covered that already? PCOS. Other medications you're taking, is it acromegaly? Remember we talked about acromegaly, which came first, giantism or acromegaly? Giantism, good. Cushing disease. If you look at your androgens, serum testosterone is usually elevated in these things. So let's do some serum androgen testing. We want to look at total testosterone and free testosterone. They're going to be elevated. Well, there's a lot of things that are out of the ordinary. If we need a manual pelvic exam, might need an ultrasound versus a CAT scan of the pelvis, because there may be cancer. Well, actually, maybe a neoplasia causing this. If we find out that there is excess androgen from the adrenal gland, and maybe it's adrenal hyperplasia, but we want to screen for Cushing's. We want to screen for late onset congenital adrenal hyperplasia. That is, I wrote this deficiency, 21 hydroxylase deficiency, which limits hormone production in the adrenal glands, and that's a congenital deficiency. That person needs to be on hormones for life. And that's somebody with ambiguous genitalia. Ambiguous genitalia happens more often than you think. And there are often parents that are, I'm not sure if this should be a boy or a girl, I'm not really sure. And ambiguous genitalia, part of virilization is an enlargement of the torus. What are we supposed, is this a penis? Is this, what is this? And it confuses parents, confuses them. So ambiguous genitalia, there's surgical reconstruction. So this late onset congenital adrenal hyperplasia is it happens more often than you think. Screen for polycystic ovary syndrome. Some of these people have type 2 diabetes, perhaps. They'll have excessive hair overgrowth, virilization. They look like they're Cushingioid in some cases. Your serum luteinizing hormone and your follicle stimulating hormone all elevated. There's amenorrhea. That's ovarian failure. Those are anterior pituitary hormones that are secreted. So many drugs that may be causing these issues. Treat the underlying disorder. This is a big workup. There might be a surgical resection of the adrenal glands. Ovarian androgenizing tumor, they happen. They certainly do happen. There's other treatments too. So it's patient kindness, it's family kindness, it's patient education. It's difficult kinds of things for patients to come and talk to you about. Very difficult. So there's, of course, there's shaving and there's waxing, there's laser therapy, there's lipolysis. There's a lot of other things you can do too. There's minoxidil. Minoxidil helps with male pattern baldness. Or contraceptives, actually, initial therapy for excessive hair overgrowth if you're not seeking pregnancy. Actually, that's a go-to drug of choice a lot of times. Spironolactone, again, is that potassium sparing medication, reduces the acne, but hirsutism and the male pattern baldness. Believe it or not, metformin enhances the anti-hirsutism effect of spironolactone, which is interesting. It doesn't do it by itself, but if you put them together, it helps with, it helps very much with male pattern baldness. Flutamide suppresses serum testosterone. Simvastatin reduces that. Simvastatin medication reduces the excessive terminal hair overgrowth in there's all kinds of things you can help them with. During primary care, are you actually doing that, you think? Probably not. But you may be the first person that sees this patient or this family that's very concerned. You might see this when you deliver a baby in your women's health rotation. Because you're going to be delivering kids. You might be doing C-sections. You might see this. That is it. So no, Professor Newman's going to go over your path though.